When you look at wait times in El Paso, the blue is primary care, the red is mental health care. These are 2014 versus 2015 numbers. Apples to apples, these are the wait times in your own words after we asked you in an independent, objective, third-party survey with a margin of error under 4%. In 2014, you told us that you waited over 80 days on average to get a primary health care appointment. You told us in 2014 that you waited almost 70 days on average to get a mental health care appointment. We asked the exact same question of a very large pool, almost 1,000 veterans, randomly selected in El Paso this year. And we found that in 2015, you waited a little bit over 70 days for a primary health care appointment and a little over 60 days, 64 days for a mental health care appointment. So you can see a little bit of progress, but these are veterans in our community waiting months, and they are not the exceptions, they are the average. They're waiting months to get in, to seek care that they have earned, that they deserve, that they have put their lives on the line for, and we're not able to deliver it in a timely fashion. That's why we're working on a plan. But the next slide, I think, tells an even more important story that we must respond to. This is the crisis in El Paso, and I would argue by extension in the VA. You told us in both of these surveys, and the numbers stayed consistent within a 1/10 of a percentage point, that 1 out of 3 veterans in El Paso could not get a mental health care appointment at all. Not in the 14 days mandated before interim Secretary Sloan Gibson changed it to 30 days, not in the 30 days that's used as the benchmark today, not in the 64 days that's the average for those who can't get in, just not ever. Just not ever. 1 in 3, and David in the graph that, or in the slide here is illustrating that with these 15 veterans, 5 of them are just never going to get in. Just never going to get in. And let me make this connection absolutely explicit, because I have met with too many surviving family members of veterans who've taken their own lives in this community. I'm talking about moms who come into our office to tell us about their son who couldn't get in to see somebody at the VA, came to one of our town halls to try to get help, and then tragically took his life when he just couldn't get the help that he needed. I'm talking about wives who have come in to tell me about their husbands who told them, I'm going to kill myself unless I get this help, and then are unable to get this help and then kill themselves. 22 veterans a day take their own lives in this country, and that's far above the general population average, and it's frankly far below what I think many of us know to be the truth. 22 is what we can measure, what is reported, what families volunteer when we're looking at cause of death in connection to service. I think the number's much higher. And when you don't have access to mental health, you are condemning more veterans to, at minimum, suffer, and in the most tragic consequences, die. And that's exactly what is happening in this community. That is why I'm here. That's why we're working on this. This is the number. These are the people that motivate us. The next slide. Here are some national issues that compound the problems that we have in El Paso and that you need to know about so that you better understand the options that we have before us. This is a picture of the job site in Aurora, Colorado that's going to serve the greater Denver metropolitan population area. And this hospital's been under construction and in planning stages for over 10 years. And it was originally only going to cost $600 million. Today, it is $1.1 billion over budget for a total price tag to you and me, the American taxpayer, of $1.7 billion to build one veterans hospital in one community. But that doesn't tell the full story. If you look at New Orleans, there's a next slide.
Looks the same.
$370 million over budget. If we go to Orlando, $350 million over budget. If we go to Las Vegas, $260 million over budget. We keep giving the drunk driver the keys to the car, and they keep crashing it. And we wonder what's wrong. The VA, in my opinion, and I hope in yours after seeing these numbers, which again are your dollars, when they're going to overages of $260 million or $300 million or $350 million or $1.1 billion, that money's not falling out of the sky from magic helicopters of U.S. currency. That money's coming out of El Paso, that money's coming out of Albuquerque, that money's coming out of Austin, that money's coming from VA pots all over the country. Okay, so not only is this shameful to you and I as taxpayers, this is unconscionable to you and I as supporters of veterans in this community who are depending on care that is unavailable because the money's tied up elsewhere. We go to the next issue. Today, and this is just the latest number that they have released. When Bob McDonald, the Secretary of the VA, first started, he told us he had 27,000 funded, unfilled positions within the VA. He said, look, I want to take care of all the veterans in this room. I wish I could. I'm trying to hire. We've got 27,000 unfilled, but I'm beating the bushes to get them out. We just heard this summer that the number is 41,000. And that's, again, their admission of their own numbers. And I always put an asterisk next to the VA's own numbers, because we've had challenges with that in the past. 41,000, and when you ask the VA, and I'm not present company excluded, when you ask the VA in Washington, D.C., how are you prioritizing that? You need foot doctors and cancer doctors and nurses and psychiatrists and psychologists, eye doctors and dentists. Who's at the top of your list? Who are you trying to get in the door? The answer from them literally is everyone. We're prioritizing all positions. So I told you how bad mental health is, and I told you how consequential the lack of mental health access is for veterans throughout the country, and that is not a priority for hiring in the VA today. It's 41,000, whoever we can get across the board. If we get 41,000 foot doctors, great. Well, that's probably not accurate, but if we hire those foot doctors first, great. Okay, so this is the problem nationally. If we go to this next slide, these are facts, okay? This is a 2008 headline, and it says, VA system, nation's worst. We weren't having town halls in 2008. I wasn't a member of Congress then. We weren't all getting to meet on this. But we, through the VA's own numbers, relative to other VAs in the country, we were ranked the nation's worst in 2008. If you go to this next slide, there's another El Paso Times headline from 2 months ago that says, El Paso last in mental health care. Here's the point I'm trying to make. And sometimes the El Paso VA, when I show these numbers, thinks I'm beating up on them, and I'm not. But I'm here to tell you that we can continue to do the same thing over and over again and expect a different result, but I think that's the definition of insanity. Or we can acknowledge that there are fundamental systemic problems at the VA nationally. More people that they have to hire that they can shake a stick at, and certainly that they can hire and bring on. Billions of dollars pouring out in overages, not original obligations, but overages to those original obligations. And veterans across the country not getting the health care that they need. And in El Paso, despite the town halls I'm holding and calling the problems in El Paso to the attention of the Secretary and his commitment to help, we're not seeing anything fundamentally different change. We're seeing some great leadership locally lately. I hope it lasts for a long time. I'm not going to count on it, and I would be a fool to do so because of the number of times that we've been in this position and never quite come out of it. We need something fundamentally new and different and bold if we're going to get a different result. A fact that you should know, right now in the El Paso VA budget, 1/3 of the checks they write are not to doctors within the VA. They're not to providers and nurses within that building on Piedras. They are to doctors and providers and health clinics and hospitals in the community. So Texas Oncology, I think, has been somebody that a lot of referrals have gone to. But I think there are some tenant hospitals, I think there are some smaller clinics, some behavioral health systems that get VA money. So right now, the VA already spends 1/3 of its budget referring care for veterans outside of the VA.
How is that?
I'll get back to this. This is really not a local issue. David will change the slide on this, but when we were trying to find out how we were going to get out of this mess, we looked for the best performing VAs in the country. And of the 13 5-star rated VAs in the country, 10 of them are affiliated with an academic medical institution. And David's put 2 up on this slide. You have Brigham and Women's Hospital, which I believe is in Charleston, Massachusetts, and it's affiliated with Harvard and maybe UMass, and it is a top performer. You have the University of Pittsburgh Medical Center affiliated with the VA in Pittsburgh, and it is a top performer. The next slide tells you what you already know, and that's why Dr. De La Rosa is here. He and President Lane have made a full-fledged commitment to the El Paso veteran and to the El Paso VA, and have said, we will partner with you the way they have partnered at Harvard, the way they have partnered in Pittsburgh, the way they have partnered at the best VAs in the country. Those doctors and providers and mental health specialists that you can't hire at the VA for whatever reason, lots of good excuses, but you just can't get it done, we'll hire them with you. We'll pay part of their salary. We'll give them teaching credentials. We'll put the feather of having the ability to teach at Texas Tech and El Paso into their cap to make it a little bit easier to attract them in the first place and retain them once they're here and ensure that they're seeing veterans in this community. We have William Beaumont Army Medical Center, which has been a tremendous partner to the VA since we've had the VA clinic up next to William Beaumont. And we have a $1 billion new facility, and I'm proud to say, so far, unless the Colonel has anything to tell me, that this sucker's on budget. We're not, hundreds of millions or $1 billion over budget. This is on budget, largely on time, and is going to be a world-class, state-of-the-art Army medical facility. It'll be right here in this community. A little bit. And here's something else that you told us from the survey. This kind of shocked me because you don't hear this from the VA. The VA says, listen, veterans in this country want to be seen at the VA. And actually what you told me, and we asked the question as directly as we could, is that you prefer access over location. So we said, tell me what's most important to you, being seen at the VA no matter what, or being seen by a doctor or a provider in this community, regardless of whether they're at the VA or in private practice. And 82% of you said, I just want to be seen in a timely fashion. I just want great care without having to wait months to receive it. I think that's pretty reasonable, and that's why this conclusion makes a lot of sense. So building on that, here's the essence of the plan. The VA can't hire 41,000 people. It just never will. We should just admit that. And so what I think we should do is prioritize the hiring and the resources connected to that hiring for those positions that are most valuable at the VA. In other words, what should be the VA's core competencies going forward. And I think those core competencies, and frankly, I'm reflecting what you have told me and other medical experts from across the community and the country have told me. Those core competencies should be treating those unique illnesses and wounds and disabilities connected to service in the military. So I'm talking about post-traumatic stress disorder. I'm talking about traumatic brain injury, military sexual trauma, Gulf War syndrome, which is now chronic multi-symptom illness. Those things that are unique to service, that the general population, by and large, doesn't have PTS or TBI or military sexual trauma. Only veterans, for the most part, have those conditions. So you want to be seen by a VA doctor or provider or specialist who only sees other veterans and knows how to do the best job possible for people in situations just like yours. That's what I'm talking about doing. And the picture here illustrates probably another core competency related to that. Those people who are living with traumatic amputations. They served in battle. They came back wounded. We want to make sure that the doctors and nurses and providers who are taking care of them know how to take care of people in situations like theirs because they've done that day in and day out. Not a doctor out in the community for whom this might be the first time or second time or third time that they're seeing it. The next part of the plan that's absolutely critical is, I mentioned that 1/3 of VA care today is referred out to the community. It's not delivered at the VA. They're sending you out to doctors already. But they're sending you out to doctors on what I would argue a very ad hoc and not especially strategic way. So you're referred out for mental health, for PTS. Even though your PTS is unique to your service and you'd like to be seen by a doctor, a psychologist, a psychiatrist in the VA, who understands that really well. You're good chance you're gonna get sent out to someone else, but only for an appointment or two until you're bounced back to the VA. And we hear from veterans from across the eras of service who say, I had my intake with a psychiatrist at the VA, it was great. They told me to come back in a week, they couldn't give me an appointment in a week. We had to wait over 30 days, which then triggered my ability to go out in the community. I got to see a provider in the community, someone brand new, once. I had to tell them my whole traumatic story all over again. Then I got bounced back to the VA, couldn't get an appointment, and I just said, fuck it, I'm not going back. I can't take it. I'm just going to suffer on my own. And I talked to a psychologist who works at the VA. And we know that these 22 veterans a day who are taking their own lives are not primarily the veterans who are returning from recent engagements. These are Vietnam-era veterans. And this psychologist at the VA told me, she said, when one of these Vietnam-era veterans comes back and they have kept this trauma, and they have PTS, they've kept this trauma successfully bottled in for 35, 40 years. And for the first time since 1971, they're going to unpack this. And they unpack it to me. And then they're not able to get that second follow-up appointment. Or they have to see somebody else, and there's not the continuity of care. That veteran would be better served had they never come in the first place. Because now they have to confront that trauma that they have released and unpacked all by themselves, or with their families, or God willing, they have a support network of friends who can help them through, or they can go get private care in the community. That absolutely cannot continue. So what we're saying is, don't, go back one. What we're saying is, for those unique service-connected issues like PTS, see veterans at the VA. Focus your hiring on psychiatrists, psychologists, therapists, and social workers, and the nurses and frontline support staff who make them effective. Every veteran with those unique signatures of war and combat and service should be seen at the VA. The VA should be a place of excellence for veterans with those conditions. Now, if you have the flu, or the cold, or you need your teeth checked, or you have diabetes, which is a really serious condition, and a lot of veterans do, or you have something else that is comparable to the general population, because people in the general population have problems with their teeth and diabetes and the flu, then maybe you'll be seen by a VA doc, because there's some very excellent VA docs who can treat those conditions, but we'll prioritize the referrals on those conditions that the general population provider force has done a great job of taking care of and treating. And so in other words, I'm talking about prioritizing and being intelligent and strategic with limited resources instead of having a Pollyanna view of the VA that you can just throw enough money and resources at it and magically we're going to hire and fix a problem that at least since 2008 has not improved in any measurable way. And then the last part of the plan. The VA in El Paso, and this is all a pilot project proposal. So we're telling the VA, don't do this nationally. Let's see if this works. Choose El Paso because, frankly, by the numbers, it couldn't get much worse. So if you're going to take risk anywhere, let's take it here. The VA would have to place a premium on the coordination of care and develop that as a core competence and something that they do better than anybody else. And that means that you, the veteran, don't just have PTS. You also have diabetes. You also need to get your teeth fixed. You also need a general checkup. You also have the flu from time to time. You will have all that care coordinated under our plan by the VA. We're going to make sure that if it's PTS, you're at the VA seeing that excellent psychiatrist that we paid, 100% more than we're paying current psychiatrists just to get them here because we're prioritizing that. And if you have the flu and you need to be seen by someone in a clinic in the community, then that's what we're going to do. But I'm going to make sure that you get that appointment. And I'm going to be your coordinator or navigator for care across the community. And I'm going to check back in to make sure you got that appointment at the VA or in the community. And I want to know what the outcome was. This is the VA's core assets in this community today. A central office co-located, it's the little blue dot in the middle, co-located with William Beaumont, the little red dot next to it. And then we have an East Side community-based outpatient clinic, or a CBOC. That's the VA today. And again, they're referring care out in the community, maybe not as strategically as I think we could do. Here's the plan. And it's not the clearest slide, so I'm just going to tell you there's a lot more dots on this map of El Paso. And you have a CBOC on the west side, a CBOC in the central part of the community, along with the existing east side CBOC, along with the presence in northeast. But you also, if you're making use of all of the partners who have pledged their commitment here, you also have Texas Tech, you also have UMC, you also have Las Palmas del Sol, you also have the hospitals of Providence, you also have Mentis Neurorehabilitation, which is the premier neurological rehabilitation outfit in this community, who pledged to take veterans in and pay VA care, or get paid VA care reimbursement rates, which is not a way to get rich. This is the idea, is that we would, at a time when we're doing a terrible job of serving every veteran who needs care, this community, one of the poorest communities in this country, is going to stand up to the challenge and open its doors, and those doctors and nurses and providers and psychiatrists and social workers and therapists are going to see everyone who needs that care, including, in the red dot up and out to the side, is William Beaumont. If we go to the next slide, this is the goal by which we'll measure our efforts. We are going to quickly and consistently connect every veteran with the care that they need, using the best possible provider for whatever it is they need, either within or outside of the VA. And then the second point, and this is really exciting, I think, for El Paso, and hopefully for the country, is we will develop a model of veteran care in this community that can improve access and outcomes for veterans throughout the country. In other words, there is no competing model to the status quo nationally for a failing VA. Let's have El Paso, who has this distinguished history of military service, also distinguish ourselves by developing the next generation model of care for veterans in this country. I know that we can do it. This community, when it sets its mind to getting something done, gets it done. And I think it's about time, I hope you agree, that we set our minds to improving the level of care to veterans in this community, and serving as a model for the rest of the country. So thanks for your patience as I go through these slides. Thank you for your help in working through some of these ideas.